So how do you manage hyperkalemia with ARNI? Strict low potassium diet, small doses of loop diuretics, you can introduce furosemide. K-bind can be used in emergency situations. And the old is gold, that is glucose insulin infusions in patients who are stubborn and resistant. So these are very, very important points. And what is the impact on the lives of patients in case you have discontinuation of ARNI? So if you find out that ARNI withdrawal can lead to repeated heart failure admissions, it can cause actually a patient who has had an improved ejection fraction can we go back to a reduced ejection fraction, and it can also increase the all-cause mortality if we discontinue ARNI. The other question which comes to mind is, should ARNI be discontinued once the LV ejection fraction improves? The so-called heart failure with recovered ejection fraction or heart failure with improved ejection fraction subset. In my opinion, no, don't withdraw ARNI, because if you have a guideline directed medical therapy, you should keep your ARNI on board and your beta blocker on board at least for a year or a year and a half after the patient has an improved ejection fraction or what we call recovered ejection fraction, because the incidence of the patient going into worsening heart failure or the patient going back to reduced ejection fraction status is very, very high. So it's very important for us to understand that keep that ARNI on board. If it's possible for a lifetime, go ahead with that patient. And what are the recommendations for heart failure with improved ejection fraction? In patients with heart failure with improved ejection fraction after treatment, guideline directed medical therapy should be continued to prevent the relapse of heart failure and left ventricular dysfunction, even if the patient has become symptomatic. So the 2022 AHA and ACC Heart Failure Society guidelines clearly recommend that we have to continue your guideline directed medical treatment. So what are the pearls and what are the take home messages which I can give you today? ARNI is the molecule of the century and is indispensable. It is superior to ACE inhibitors in reducing cardiovascular death, heart failure hospitalization, and sudden cardiac death. Heart failure is a disease of epidemic proportions in India. ARNI improves the left ventricular ejection fraction in heart failure with reduced ejection fraction and reverses the adverse LV remodeling and improves the quality of life in our patients. ARNI should be initiated as early as possible in patients with acute decompensated heart failure and also in de novo heart failure. And here time is life years. ARNI should be given for at least 3 to 6 months along with other foundational therapies for heart failure with reduced ejection fraction. LVEF should be reassessed with echo or cardiac MRI before any patient is considered for ICD or CRT. ARNI should be used in all patients with heart failure with preserved ejection fraction up to an EF of 56 to 60% along with SGLT2 inhibitors to reduce hospitalization for heart failure and also to improve the quality of life.